Welcome to the Antibiotic Stewardship and Nursing Facilities webinar. My name is Adrienne, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. I'll now turn the call over to Diane Doan. Diane Doan, you may begin.
Hi, this is Diane Doan from the Lake Superior Quality Innovation Network. The Lake Superior CLIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is intended for all nursing homes in Michigan, Minnesota, and Wisconsin who are participating in the National Nursing Home Quality Care Collaborative. Today's webinar is the last in our four-part series. These webinars are designed to assist your nursing home in improving quality of care and outcomes for residents, as well as meeting the reform of requirements for long-term care facilities infection control requirements. A summary of questions and answers from all four webinars will be compiled and posted on our LSQIN website shortly after today's webinar. As stated, all lines will be muted during this webinar. However, if you have questions during the presentation, you may ask them in chat. If the chat box is not visible to you on your screen currently, you may have to click on the arrow in front of the word chat to expand it and to be able to see the comments and questions and the resources currently being listed there. There will also be an opportunity to ask questions by phone after the presentation. I would like to now introduce our speaker for today. Dr. Crnich is the Chief of Medicine and the Hospital Epidemiologist at the William S. Middleton VA Hospital and is an Associate Professor of Medicine in the Division of Infectious Disease at the University of Wisconsin School of Medicine and Public Health, where he teaches graduate students, fellows, and residents. He has a general research interest in healthcare-associated infections among vulnerable elderly patients with a specific focus on antibiotic resistance in long-term care facilities. He currently receives research funding from the Wisconsin Department of Health Services as well as the Agency for Healthcare Research and Quality to study and develop interventions to improve patterns of antibiotic use in nursing homes. I would now like to welcome and turn the presentation over to Dr. Crnich.
Thank you, Diane, for that introduction. Do I have control here?
Adrian, can you make sure that the control is handled to Dr. Crnich so that he can advance his slides?
1 minute. Emily, can you help?
If you left-click on your slides with your mouse, that will activate them, and then you can use the page-down key on your keyboard. Or if you look directly above your slides, you'll see a box that says 01 Antibiotic Stewardship, and on either side there's arrow buttons you can click with your mouse.
Is that advancing the slides now?
Yes.
All right, very good. Before I jump in, I just want to provide some disclosures. As Diane noted, I do receive research funding from a variety of funding sources, including the federal government and the VA government. I do consult for two companies, one focused on cutaneous antiseptics and the other focused on hand hygiene, and neither of these relationships should impact what I'll be talking about today. So what I'm hoping to go through is provide a very brief rationale for why we should be doing stewardship in nursing homes. I know that this has already been covered in a number of the prior talks, so I won't spend a huge amount of time in that area. Would like to spend some time talking about what we mean by antibiotic stewardship, what are some of the barriers to achieving stewardship in nursing homes, and then really start talking about where should we be focusing our efforts in nursing homes, along with suggestions for how to prioritize various stewardship activities, and where to go next once kind of the basics have been addressed. So I'm not saying anything that people haven't heard already. In healthcare, we have been prescribing antibiotics far too much, often for things that don't require antibiotics. However, even when antibiotics are required, often we're using those agents inappropriately, either too broad a spectrum, too long of treatment courses. And this has resulted in a lot of consequences that are really coming home to roost now. And as a result, there is a lot of interest in trying to identify effective strategies for improving the use of antibiotics, not just in hospitals, but also in the clinic and certainly the long-term care setting. So when you look at how much are we utilizing antibiotics in nursing homes, we're using a lot. Residents who spend at least 6 months in a nursing facility will, in the vast majority of cases, get exposed to at least one course of antibiotics. Studies that we've done in Wisconsin, which is very consistent with other data collected at a national level, have shown that 2/3 of residents who stay in a nursing home for this period of time will have at least one antibiotic course. We found that in one of our studies, one poor resident got 14 different courses of antibiotics over a 12-month follow-up period. And repeated antibiotic exposures, unfortunately, is not an uncommon occurrence in these facilities. And when we hone in on the appropriateness of the antibiotic use, we find that less than half of the antibiotic courses, whether you're using something like the McGeer criteria, the Low criteria, are appropriate. Recognizing that these criteria do have some limitations, probably several of these that didn't meet criteria were certainly clinically appropriate, but when you see an appropriateness rate that's below 50%, you know there's still a lot of room for improvement. Even when those antibiotics are appropriate, however, there's a tendency to use high-risk antibiotic agents, as evidenced by the left-hand side of this figure, showing that the fluoroquinolone antibiotic class, which is really our most broad-spectrum antibiotic class available to us in the nursing home setting, is the most frequent antibiotic agent prescribed. And then the beta-lactams, often using broad-spectrum beta-lactam, beta-lactamase inhibitors, or advanced generation cephalosporins, are the next most common class of antibiotics employed in this setting. And our more narrow-spectrum agents, such as sulfa, tetracyclines, really are a minority of utilization in these facilities. And then the other characteristic of antibiotic prescribing that we see in our nursing homes is agents are often prescribed for a very prolonged period of time. Again, this is data from our studies in Wisconsin facilities showing that on average most infections are treated for about 7 days, which is great. But in this slide on the right, you can see that over half of the antibiotic courses were prescribed for longer than 7 days, sometimes in excess of 2 weeks for things like UTI or pneumonia, where there's clear-cut data that 7 days or sometimes even less is just as effective as longer courses of therapy. So there's actually a lot of opportunity to improve the safety of antibiotic prescribing by focusing on type of antibiotic selected and duration of antibiotic prescribed. Now, when we look at the effects, it's important to understand that these effects exist at multiple levels. Obviously, there is a harmful individual effect. So we now know that antibiotics are one of the most common causes for adverse drug events. In fact, in a number of studies, antibiotics have been implicated in 20% of all adverse drug events observed in the nursing home environment, and transfers to the emergency room for antibiotic-related adverse events is very common in nursing homes. Obviously, we're concerned about antibiotic resistance, and there's plenty of evidence that preceding antibiotic use is associated with a significant risk of future infections with antibiotic-resistant organisms, which confer a higher risk of death and certainly make treating those infections more difficult and more expensive. And then the other major concern is Clostridium difficile, which I know you guys had a presentation on already. But nursing homes are one of the most common locations for the incidence of C. difficile. In fact, in a number of studies, nursing homes account for the majority of C. diff cases in states and hospitals, while still a major site of C. diff onset represent a minority in many of the existing published studies. But it's also important to note that antibiotic use is very unique compared to other medications. So giving a resident a blood pressure medication has no impact on the health of other residents in the nursing home. That's not the case with antibiotics, where we now have fairly compelling evidence that giving an antibiotic to one resident confers some risk of harm to other residents in the facility. This is a really nice study from Nick Damon up in Ontario, Canada, and they looked at 607 nursing homes, followed 110,000 residents for 2 years, and they were interested in looking at a number of antibiotic-related harms, including C. difficile, diarrhea not related to C. difficile, and then infections caused by antibiotic-resistant bacteria. And what they did in the study was very interesting. They looked at these outcomes in residents who never got an antibiotic during the study period. So during this study, a majority of residents did get an antibiotic, nearly 80,000 residents, but about 30,000 residents never received a single course of antibiotic during the 2-year study period. And what they found was residents who were not exposed to an antibiotic but resided in a nursing home that was a high utilizer of antibiotics, as indicated on that left side of this slide, had about a 24% higher risk of experiencing one of those antibiotic-related harms compared to residents who did not get an antibiotic but lived in a low-utilizing nursing home. So there is this ecological fallout that we are putting residents in our facilities at risk for by prescribing antibiotics to residents. And then the other area, which obviously is getting a lot of media play and policy play, is the risk of antibiotic resistance at a population level. And this figure on the left here in this slide is a study from Chicago looking at the spread of carbapenemase-resistant Enterobacteriaceae in the Chicago area. And they went into the study thinking that certain hospitals would be the main risk for spread of CRE. And what they found was, by the social network analysis study, that a long-term acute care hospital and actually 3 nursing homes were the major settings for promoting the spread of CRE in the Chicagoland area. And we now know that about 75% of the hospitals in Chicago have treated at least one patient with CRE. We've been fortunate in Wisconsin to avoid a lot of this spread, although it's probably only a matter of time. And it's important to note that this relationship has not just been seen with things like CRE. It's also been documented with VRE or vancomycin-resistant enterococcus and methicillin-resistant Staph aureus. So this has led to a lot of governmental and policy consternation. Some of you may have seen this policy document released by the CDC, which focused on a national action plan to combat antibiotic resistance, and they had a specific area focused on long-term care facilities. So this has been on their radar screen for many years now. When you look at the Presidential Advisory Scientific Committee, they released this action plan in 2015, and again, long-term care facilities were explicitly highlighted as an area for focus. And this is translated directly into the recently released requirements for participation, which mandates that facilities now have an antibiotic stewardship program in the long-term care setting. So that's really what I want to focus on today is how do we implement or start to implement an antibiotic stewardship in a long-term care facility. But before we do that, it's important to understand that this is a process that requires some accountability. So it's really important that facilities identify an individual who's responsible for the antibiotic stewardship program. This can be the infection preventionist, it can be the director of nursing, it could be a pharmacist, it could be the medical director for that matter. But it's really important that there is a single individual who has accountability for the program. But the other thing to remember is that stewardship really is a team effort, and far too frequently in nursing homes, almost all the heavy lifting gets done by nursing staff, or the infection preventionist is often part of the nursing staff, and there often is limited involvement of the pharmacist or the medical director. And that's something that's really going to have to change if we're going to be effective in implementing stewardship. We really need to have all of these individuals participating in this program. The other thing that I want to highlight is that there are a number of resources that I think can serve as a nice template. In the middle is the core elements of antibiotic stewardship for nursing homes. There is a risk assessment tool that is available on the website at the CDC, which I think is very useful for doing a readiness assessment of where your facility is at. And a lot of the items that I'm going to cover today map directly to the core elements. And if you look at the interpretive guidance that has come out for the requirements of participation, a lot of the core elements in this document have shown up in the interpretive guidance. So I think if you're looking at this resource and implementing it in your facility, you're going to be in a good position for the survey process. So what are kind of the tasks that we're talking about from a stewardship perspective? Well, I think that there are a couple of big categories that I want people to be thinking about. So first is focusing on that decision to start an antibiotic, or what we call pre-prescribing activities. And there are a number of tasks and strategies that facilities can employ to make sure that those antibiotics that are getting started are getting started for appropriate indications. But it's also important to think about after an antibiotic has been prescribed, are there things that we can do to make an antibiotic safer? And I'll spend a little bit of time talking about that. And then the other thing that I really want to focus on is there is a big nursing component to this. So a lot of times when I'm out in nursing homes, I hear, well, this is a prescriber issue, and there's no doubt that the physician or the nurse practitioner have ultimate responsibility for that antibiotic order. But there are a lot of things that influence those decisions, and there's actually a lot of opportunities for nursing staff to exert some influence on those antibiotic decisions. And so when I kind of look at stewardship in nursing homes, I think it's really important to note that having a solid SBAR process in your facility is actually a key stewardship activity. A lot of people focus on SBAR or the Interact tools as being a mechanism for reducing unnecessary hospital transfers, but I think that if you're putting a lot of emphasis on improving the quality of your SBAR process, you're going to have some positive impact on prescribing. I'll actually show you some data to support that statement. I think the other area where nursing can focus a lot of activity is on reducing or limiting the use of unnecessary urine testing. A lot of antibiotics get started in nursing homes because somebody ordered a test unnecessarily, and it's amazing how much of a trigger this is for providers to start antibiotics. So if your facility is really putting some effort in reducing urine cultures you can actually have a big impact on prescribing through that intervention alone. And then the other thing related to this post-prescribing is getting providers to engage in an antibiotic timeout, reviewing the antibiotic and whether there's opportunities for changing it and making it safer. Really is an activity that we need to be moving in the direction of. So I kind of stratify these interventions or activities into core activities. These are things that I think every facility should be making some plans towards moving towards. And then the other areas which I consider advanced, I think certainly are desirable, can be impactful, but I don't think they should be the first things that facilities should be focusing on. I think that get the core activities in place first and then move on to the advanced topics. So let's talk a little bit about what I mean by policy and procedure. So I think it's really important that facilities, if they have rapid reagent test strips in their facility, that they focus on getting those out. There's a lot of data now showing that these are very poor indicators of infection, and they serve to trigger a lot of unnecessary urine cultures. And so dipping the urine is something that you want to really focus on, and that really needs to be part of your policy, that you shouldn't be doing rapid reagent strip testing. I think it's really important to look carefully at your nursing delegation protocols. A lot of physicians or nurse practitioners will write standard orders for change in condition, get a urinalysis, and urine culture. I think that you want to be very careful with those types of delegation protocols to make sure that they're not leading to over-testing, which I'll show you later on is a big trigger for unnecessary antibiotic use. I've already mentioned a little bit the SBAR process. Again, I think it's really important that facilities have a policy and procedures for how to assess and communicate resident change in condition, make sure that this is included in documentation, that there's a system for assessing the quality of that assessment and communication, and providing feedback to staff who are not doing this consistently, and certainly incorporating this into onboarding and orientation is really important. This needs to be part of just the culture of how things are done in your facility. This fourth bullet point I don't think can be underemphasized. This is clearly detailed in the interpretive guidance. I think this is going to be ripe for surveyors when they come in. If your antibiotic orders don't have an indication for that antibiotic, the drug, the dose, and the duration documented somewhere in the chart or the MAR, that's going to be an easy citation. So this is something that needs to be consistently and reliably done in your facility. And it's amazing how often an indication for the antibiotic is not detailed in the chart. I already talked a little bit about urine testing, but another common practice that we see are test of cure urine cultures. There's almost never a good reason to do test of cure urine cultures. Many residents are persistently bacteriuric, and all you're going to be doing is chasing urine cultures and leading to antibiotic course after antibiotic course. So if you've got providers doing this, you need to get this in policy that it's prohibited against your facility policy, and you need to be engaging your medical director to be providing feedback to providers. And then the use of prophylactic antibiotics, while it has certain indications, for a urinary perspective, there's almost never a good indication for prophylactic antibiotics for prevention of UTI. All that serves to do is cultivate ever more resistant bacteria and eventually fails. So again, this is another area where engaging your medical director is really important in getting this into policy, so providers who are admitting residents to your facility kind of know that this is a cultural no-no. Education and promotion of stewardship, again, we kind of often or frequently rely on education as our only strategy for improvement, and certainly I don't think it's the only thing you should be doing, but it's really important that nursing staff and providers have education on the importance of stewardship, and in particular for nursing staff, highlighting what are the areas that they can engage in to impact better antibiotic use. I've given you a URL here to a nursing education website. There are 5 or 6 modules here focused on very brief educational interventions. One is appropriate assessment of risk. The other is appropriate collection of a urine specimen, which is really important for getting a good urine culture. A lot of times if this sample is collected poorly, you get multiple bacteria in culture, and unfortunately that leads to more broad-spectrum antibiotic use than is necessary. So nursing staff can really positively impact care by getting a high-quality urine specimen and making sure that you're minimizing contaminants. And then things related to catheter care are really important for reducing a resident's risk of infection. So this is a nice website to direct your nursing staff to if you don't have something that you already employ. Family engagement is also pretty important. I will admit, though, that there's not a lot of good research right now in the long-term care setting on the actual impact of family education, but there's no doubt that family preferences are a big driver for antibiotic use in nursing homes. I have given you reference here to 2 different resources. One is a toolkit site maintained by the Agency for Healthcare Research and Quality, and then the other is a North Carolina, or I take that back, a Massachusetts website that they put together on materials for family members. My big advice is developing education for families and administering it outside of a change in condition, trying to engage a family member in decisions about appropriate antibiotic use while their loved one is experiencing a change in condition, I think can be very counterproductive. So I think trying to do this up front when residents are admitted to the facility, doing this during resident committees or family, if there is kind of a family meeting session that your facility has, incorporating this type of learning activity can be very powerful. And really emphasizing that we're going to be monitoring your loved one carefully. Our goal is not to prescribe antibiotics where the risk of infection is low, because these antibiotics have a lot of side effects, and specifically explaining why you're trying to use antibiotics more judiciously and really focusing on this is part of delivering high-quality care to your loved one. There's a lot of myths that get built up over time, and breaking these down can require a lot of effort. Now, another area that I think is going to be a big one from the survey process is having a system for showing that you're tracking and reporting antibiotic utilization and outcome measures. This is considered a core element. It is explicitly mentioned in the interpretive guidance. So it's really important that your facility have some system for tracking antibiotic use and antibiotic-related outcomes. And again, this is just a good practice from a quality improvement perspective. If you can't measure it, it's very difficult to improve it, at least according to Lord Kelvin. So when the interpretive guidance says you need to be tracking antibiotic use, it's important to note that they don't tell you in the interpretive guidance what you should be tracking or how you should be tracking it. So you're going to have a fair amount of flexibility. What is going to be looked at, though, is the facilities are going to expect this to be somewhere in your policies and that you're following your policies. So an example of a utilization measure would be antibiotic starts per month or per 1,000 resident days. An outcome measure would be numbers of C. difficile or MRSA colonized residents per month or per 1,000 resident days. I want to make it clear that an antibiogram is not required. It is mentioned as one way of tracking antibiotic-related outcomes, but it is not a requirement. And as I'll talk about a little bit later, there's a lot of issues or difficulties with operationalizing antibiograms. And I think if you're going to do that, you should use it in an effective way. And if all you're doing is getting an antibiogram from your reference lab and you have a mixture of cultures from their hospital and other nursing homes, it's not going to be very useful. So if you can get a facility-specific antibiogram, great. I think it can be a very powerful tool, but I think you want to be careful, and it's important to remember that this is not required by the survey process. It's just listed as an example of one type of antibiotic outcome. The other thing to remember is that facilities will be expected to perform some type of appropriateness assessment. And again, this does not need to be done with every antibiotic. It might be just for urinary tract infections, for example, or it might be that you only want to look at a handful every month just to see how many of those are meeting appropriateness. Again, the interpretive guidance is not saying how you should do this, but there should be some assessment of antibiotic appropriateness going on in your facility. Again, this is another area where the surveyors shouldn't be telling you what criteria to use. So if a surveyor comes in and says, you're not using the gear, we're going to cite you for that, that is actually not correct. The interpretive guidance does not state or make a preferential statement for one type of criteria over the other. I think McGear is fine, Loeb is fine. If you have another type of appropriateness criteria, that's fine. What I would say is get it in your policy and make sure that your facility is following that appropriateness criteria and be able to demonstrate it through your documentation or tracking perspective. But this is a common area of confusion that comes up a lot. So when we look at which antibiotic utilization measures should we be using, I think an antibiotic start is a fine measure to use. In fact, many facilities are already doing this. It's aligned with the 24-hour report. It's pretty easy in many facilities to find out which residents on the 24-hour board are receiving antibiotics, and it's also aligned with what the infection preventionist is often doing. So I think that this is already something that facilities can do relatively easily or incorporate into their infection surveillance process. The problem with it is it obviously doesn't take into account prophylactic antibiotic use. So somebody who's been on Bactrim or doxycycline for months and months will not show up. It doesn't track appropriateness if you're just looking at the antibiotic start. And if you are having a lot of problems with duration of therapy, for example, antibiotic starts may not be the right measure you want to look at, and you may be wanting to look at duration of therapy or number of antibiotics courses that are prescribed for more than 7 days, for example, if you know you have a lot of problems with duration of therapy. So I think it's a really good place to start, but it may not be the only measure that you want to use depending on where you think you need improvement in your facility. Now, days of therapy is another measure. In fact, hospitals that participate in the CDC NHSN reporting structure use days of therapy. This does capture duration of therapy, and so can be a good measure. If you know you have a lot of problems with long courses of antibiotic therapy, doing a days of therapy measure can be very useful. This can be difficult to get data for, though. I think as more and more facilities move to electronic medication administration records, this is actually going to be quite amenable to automated reports. And if you have a consultant pharmacy, this may be a item that you want them to build out, particularly as you're negotiating your next contract with your consultant pharmacy, having them create days of therapy reports from their data, because they have this data. They have start dates, they have end dates. They should be able to give you days of therapy broken down by type of antibiotic, and if indications are getting into your system, that's another way that you can also get this by condition. Again, I don't expect that most facilities will be able to do this currently, but as more and more go online to electronic data systems, this should become easier to do. But again, not required. I want to be very clear here that these are suggestions. This is not a requirement. Appropriateness, I've already kind of alluded to this. This is just an example of McGear versus Loeb criteria for appropriateness for urinary tract infection. They're not the same thing. There is a fair amount of overlap, but not complete overlap. What I would say is pick one and stick with it. If you want to do a different one, that's fine too. Just make sure that it's made very explicit in your policies and be able to show that you're using one or more of these measures when the surveyors come in. I think another area for appropriateness is duration, and I really like this idea of antibiotic courses prescribed for more than 7 days. Seems like a fairly straightforward way to incorporate into your 24-hour board, so you can be tracking antibiotic starts and whether that antibiotic start was prescribed for more than 7 days or less than 7 days. And I think if you're doing those two things, you'll be meeting the survey requirements both for tracking utilization as well as tracking appropriateness of antibiotic prescribing. Here are a couple of other examples. Again, I think these can be very effort intensive, but can also be very impactful if you know you have a problem. So looking at a specific class of antibiotics like the Fluoroquinolones, for example, might be an area that some facilities want to look at. At our hospital, for example, we've restricted the use of Fluoroquinolones, and they can only be prescribed if approved by an infectious disease provider. Obviously, that's not going to be practical in the vast majority of nursing homes, but deciding that you're going to focus on reducing Fluoroquinolone use certainly is one opportunity, and this would certainly be a quality measure that you would want to be tracking if that was the case. Another idea, if you can't be tracking events on a prospective basis, it's certainly reasonable to track this stuff cross-sectionally. So pick 1 week where you're going to track the antibiotics started for 1 week, do an assessment of appropriateness for starting, whether it was a high-risk antibiotic like a fluoroquinolone, and looking at duration. If you were to do that once, 1 week for each quarter of the year, again, I think that would be certainly a defensible approach from a survey perspective. So again, the other idea here is you can offload this to frontline staff, have an infection log that captures some of this information, so frontline staff are helping with some of the data collection, particularly in facilities that don't have a robust electronic data system. Doing this with just a form is another way to get some of this data collected, and then your infection preventionists can aggregate this into monthly reports. These are just some ideas. They're not recommended practices per se, but I think thinking about what's feasible in your facility and then developing your surveillance and reporting system around your resources and what's feasible, I think is really important. And then getting that into your policy, so when the surveyors come in, you can show this is what we decided as a facility, and then be able to demonstrate that you're meeting those self-prescribed tracking and reporting processes. So I'm going to just blow through these slides because I've already kind of largely talked about this. The one thing that I would say, that last bullet point, be really careful when you're trying to benchmark yourself to other facilities. Right now, there is no national database that allows facilities to compare themselves from one facility to the next. And until there's a standardized approach, you may not be comparing apples to apples. And so the big thing here is to look at where you're at currently and track your progress over time. So you're doing internal benchmarking rather than external benchmarking. Obviously, as external benchmarks become available, I think this will be easier and easier for facilities to determine, where are we at? Are we an outlier? Do we really need to improve? But until those resources become available, I think you want to be careful about whether your data is actually equivalent to what other facilities are collecting. From other core activities, again, I've already mentioned the SBAR process. I think as a clinician, when I'm asked to make a decision over the phone, it's really comforting to hear a complete assessment, information on vital signs, what exactly was the change in condition, what were the pertinent exam findings, what is the data that we have available on this individual, really makes that decision a lot easier. And whether you believe it or not, when I'm on the phone with a nurse or another provider, I'm often trying to figure out what do they want from me. And so recognizing that person on the other end of the phone is trying to figure out what you want is to your advantage. So if you think that a course of action should be done, make that recommendation explicit. Don't allow that to be interpreted inappropriately by the provider. If you think this is a low-risk change in condition that doesn't require testing of the urine or initiation of antibiotics, then state that. A physician may not take that assessment, may decide to go in a different direction, but if you feel confident about your assessment and a recommended plan of action, there's no reason why you can't make that explicit in your conversation. And then the other thing to remember is that often our most important tool or tests for determining whether an infection is present is resident trajectory. So being able to give that provider on the other end of the phone what's been going on with the resident over the last couple days is really important for determining whether this is actually an infection or just some other non-infectious reason for the change in condition. And here's some data that from a study done in several Texas nursing homes where they did attempt to implement an SBAR communication tool focused on a UTI communication tool. And what they found was facilities that implemented this SBAR communication tool with fidelity had about a 24% lower rate of antibiotic prescribing compared to facilities that didn't implement it or implemented it with poor fidelity. So good communication does lead to better antibiotic prescribing based on this study. The other area where I think nursing homes should probably put a lot of resources is in reducing urine testing, and as a result, I think that facilities should be tracking their urine culture rates and trying to drive that number down. This is a study showing that about 80% of the antibiotics prescribed for UTI in nursing homes occur only after the urine culture results come back. So a lot of times it's that urine culture results that is driving the decision, and other clinical findings often play a limited role in the antibiotic decision. So this is telling you that you can control antibiotic prescribing in your facility to some extent by controlling urine cultures. And we've implemented in a couple of our studies a decision tool that helps nursing staff stratify residents into higher versus lower risk of infection, and really pushing active monitoring without testing or treating in those residents who have low risk change in condition. Really focused on simple questions. Does this resident have a change in their vital signs? do they have any localizing urinary symptoms? If the answer to both of those questions is no, and all you have is isolated behavioral change, then this is probably a low-risk resident, and what we should be doing in that situation is put them on the 24-hour board, monitor their vital signs every shift, hydrate them, look to see whether there are new medications or environmental triggers that are causing the behavioral change. But don't automatically test and treat these people. Many of them will get better on their own, and if they don't, then it's reasonable at that point to do testing and treating. And so again, this is an approach that we're really trying to advocate in our facilities. And this is a study from Massachusetts where they focused on really reducing unnecessary urine culture. And what they were able to do is drop their urine culture rate by over 50% in the 12 nursing homes that participated in this collaborative. And they dropped their UTI rate by 60%, and they dropped their C. diff rate by 15%, simply by focusing on unnecessary urine cultures and reducing the frequency of unnecessary urine cultures. So if you can drive your urine culture rate down, I guarantee you're going to drop your antibiotic treatment rates down as well. And then the last core activity that I want to highlight is this concept of an antibiotic timeout, and this is made explicit in the core elements and is also referenced in the interpretive guidance that was recently released. So we really want to see providers circling back on residents usually 2 to 3 days after an antibiotic has been started. Often by that time, all of the diagnostic information like cultures or x-ray information is back. And you've often had the benefit of seeing whether the resident is responding appropriately to antibiotic therapy. And it's really at that point that it's a good time to look at could we modify this antibiotic regimen to make it safer? And really what I try to get providers to buy into is this concept of 3 S's when they're doing that antibiotic review. Should I stop the antibiotic? Should I streamline the antibiotic, meaning switch it from a broad spectrum to a narrow spectrum agent? And the last question is, can I shorten antibiotic therapy? So is this resident currently scheduled to get 10 days of therapy and they're really turning the corner quickly, so maybe I can safely shorten that to 7 days or maybe even 5 days depending on the infection in place. And when we went in and looked at urinary tract infections in several of our nursing homes participating in one of our studies, we found that nearly 2/3 of the antibiotic courses were amenable to some form of de-escalation. Over half of them could have been stopped. A lot of these were residents who went to the emergency room for an unrelated condition like a fall, and they came back on an antibiotic for UTI because their urinalysis was abnormal. So doing this antibiotic review can actually do some course correction on a lot of those emergency room initiated antibiotic courses. About 20% of the antibiotic courses were amenable to some form of streamlining, and at least in our state, we're pretty good about duration of therapy. Only about 10% of them were amenable to shortening, but certainly data from other states suggests that long duration therapy is a bigger problem. So there is a lot of opportunity for improving antibiotic safety if you can get your providers to engage in this antibiotic review consistently. And the way that we kind of operationalize it from a nursing staff perspective, the first step is the provider needs to know that their resident was started on an antibiotic. A lot of times they do get notified, but it's a week or 2 later. So having a communication system for letting the primary care provider know that their resident was started on an antibiotic the next business day is really important. I think reassessing the resident, that clinical trajectory is really important. So when you call the provider and engage them in this antibiotic review and the resident is back to their baseline, that's really reassuring information. And providers feel a lot more comfortable with changing or shortening antibiotic therapy if the resident is improving. And obviously, if they're not, then they should be looking for other explanations for why they're not getting better. And then really engaging the providers to be asking those three questions is what we're looking at. And this isn't going to lead to an antibiotic change in every situation, but if you're doing this consistently, you're going to see a lot of improvement in antibiotic safety, and this is really what we're talking about when we are talking about implementing an antibiotic timeout. Now, I've already mentioned the facility antibiogram. I think there's a lot of myths or misconceptions about the antibiogram. So I want to, again, be very clear that the survey and interpretive guidance does not say you have to be doing an antibiogram. They suggest it as an antibiotic-associated outcome. But if your facility does not have access to facility-specific antibiogram and what you're getting is your reference lab antibiogram for all of their sites, it's not going to be very useful, and so I would not recommend implementing this if that's all you have available to you. But if you do have a facility-specific antibiogram, I think that this can be very useful, particularly if you're seeing a lot of resistance. This is data on the left from several nursing homes in Wisconsin, all within about 10 miles of each other. And you can see that there's a lot of variation in the percentage of bacteria susceptible to different types of antibiotics. These were fluoroquinolone antibiotics, and you can see that facility C has a lot of problems with fluoroquinolone resistance. So in that facility, there's no reason why you should be empirically prescribing fluoroquinolone antibiotics because it's not going to work, whereas in facility B, it might be very reasonable to use a fluoroquinolone from a susceptibility perspective. And this was kind of hammered home in another study done by J.J. Peruno in Colorado. And what they found in 3 nursing homes that they looked at, over half of the antibiotics chosen for treatment of UTI were a fluoroquinolone. However, 80% of those isolates recovered from urine cultures were resistant to fluoroquinolones. And when they showed this data to providers, the use of fluoroquinolone antibiotics dropped dramatically. So having this information and feeding it back to your providers can be very powerful and can change their prescribing behavior. But again, it's really important that you have facility-specific data. If you're just providing regional data or hospital data, it's not going to be as useful or impactful. I'm going to finish up with a few and then leave some time for questions. I think having a facility-specific prescribing guideline, what are our first-line treatments for UTI or pneumonia, can be very useful, both from an educational perspective and for driving practice, but obviously it requires some effort, really needs to involve your medical director, and having an ID provider to review and provide input can be very helpful. But again, still not widely available, and one of the big holes we have at a national level is that there's not currently a nursing home-specific prescribing guideline out there, which makes it challenging. But if you do this, you can drive inappropriate antibiotic use down. This is data from a single facility in Chicago showing a significant reduction in antibiotic use and an increase in guideline concordant antibiotic therapy. This is a national guideline in the Netherlands showing implementation of a national prescribing guideline for nursing homes dropped inappropriate antibiotic use, here the use of fluoroquinolones. And so, again, guidelines are very helpful, but difficult to operationalize in most nursing homes. And then I'm going to finish up with doing audit and feedback. So actually giving providers a review and giving recommendations. This is something that we do commonly in hospitals. I think it's going to be really difficult to do this in the nursing home where you've got a pharmacist or perhaps an ID trained physician reviewing antibiotic courses and giving recommendations for modification. I think that trying to provide recommendations for how providers can self-correct their antibiotics is certainly one way to do this. But again, very effort intensive. You need to have some people in the facility with some expertise or have access to people with expertise and most facilities aren't going to have that at this point. This is a study that was done in California nursing homes. They had a pharmacist reviewing antibiotic courses for UTI and giving feedback to providers, and they were able to drop their inappropriate antibiotic use by about 60% through this type of review and feedback. So definitely can be impactful. Again, whether the facility has the resources and the expertise to do this, I think, is the really big limiting step. And then finally, giving report cards to providers is another strategy that I think could be very impactful. We all think that we're doing better than we actually are, but we have a really nice story in one of our Wisconsin facilities where the medical director provided providers with an antibiogram, and then over the course of time identified providers who were prescribing antibiotics at a high rate and using broad-spectrum antibiotics, and he sent them a Dear Doctor letter calling them out on their practice, and they were able to drop their antibiotic prescribing by almost 45% through the use of this type of provider report card. So again, can be very powerful, really good way to engage your medical director, but again, can be associated with some political fallout and needs to be operationalized very carefully, but definitely something that can be impactful. And I know I'm running up against my time. I'm going to stop there. There are a lot of good resources out there that can point you in some directions that maybe I haven't touched on or provide further detail on some of these suggestions. I know that Minnesota and Wisconsin both have websites, but North Carolina and Massachusetts have a very nice website, and as I mentioned, the Agency for Healthcare Research and Quality does have a stewardship toolkit that has some very nice elements. And so there, I'm going to stop and try to address some of the questions that were pointed out. Diane, did you keep track of those questions?
We have 4 questions in the chat.
Okay.
The first 2 are related to urologists.
Yes.
What about urologists who use prophylactic antibiotics? How do we change that? It's kind of a related question you may want to answer at the same time. What about the patient with renal stones and recurrent infections, pyelonephritis? If they get infections every 2 months and a urologist puts them on in prophylaxis, how do we address that?
Yeah, I think that is a very challenging issue, and it's a question that I've heard repeatedly. There's no convincing evidence that antibiotic prophylaxis for urinary tract infections is effective in the long run. It can be effective in the short term, generally over a time period of 1 to 3 months, but eventually over time, the patient's urinary tract gets colonized with bacteria that are resistant to the antibiotic that they're on. And so what you end up doing is chasing your tail chronically to the point that they are infected with Pseudomonas, Candida, and Enterococcus, which are very challenging organisms to treat. There are a number of non-antibiotic approaches to preventing urinary tract infection, and what I would advocate or recommend is if you're getting a urologist who's consistently putting residents on antibiotic prophylaxis, consider a referral to an infectious disease provider or consider a referral to a different urologist. I know that that's not perhaps a very palatable solution, but there's a lot of uninitiated, I guess, in urology where this is still considered an acceptable practice, even though pretty much all the national guidelines, including the urological national guidelines, discourage the use of prophylactic antibiotics for the reason that I just described. So at the end of the day, I think getting another subspecialist input or a different subspecialist input is probably the way to go in that scenario.
Thank you. And perhaps one final question as we're running out of time. How effective are oral antibiotics in the elderly, considering their inability to metabolize drugs efficiently versus an IV drug, which of course would go directly into the bloodstream?
So unfortunately, a lot of this depends on the type of drug that you're describing. So there are certain oral antibiotics that achieve blood levels the same whether you give them by the oral or the intravenous route. So an antibiotic like ciprofloxacin gets absorbed very well and achieves blood levels very similar to IV as long as you're not giving it with cationic agents like calcium, magnesium, or iron, which can bind that antibiotic and prevent its absorption. Bactrim is another antibiotic that gets absorbed very well and it achieves very good serum levels. So a lot of this depends on the specific type of drug. And that's why having somebody with antibiotic expertise can be helpful, like a pharmacist or an ID provider, which can take into account these differences. But most of the antibiotics that we use for common infections are very effective when given by the oral route. And generally, the main advantage to IV antibiotics are when we're running into situations with resistance, where the only effective antibiotics for a resistant organism is intravenous. So I'm certainly not saying that it's a simple issue, but in general, oral antibiotics for most of the common infections that we encounter in the nursing home setting are as effective as intravenous alternatives.
Thank you so much for your wisdom today. There are additional questions in the chat box, which unfortunately we don't have time for. If you are willing, I will get those to you for your input, and then we will put them on our FAQs, which will be released and put on our website shortly after today's webinar.
Very good.
Thank you so much.
All right. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.